hosting well over 130 student interns a year and over 700 additional for topical seminars. Shout out to all of our special guests. Thank you for interacting with our great students that are here for their final day on a fly-in on the future of health, innovation, and equity. We also like to bring the magic of Miami to Washington, D.C., and know that our hometown is also the perfect lab for a lot of the challenges our faculty are addressing. Quick satisfaction guaranteed offer. If you're ever passing by, the best of Cuban coffee is offered here at any time of the day. And there you go. And finally, we're here to collaborate with our partner universities like we're doing today. So we're excited that today's program also includes accomplished researchers from our sister institution, the University of Florida, University of South Carolina. We know we have some representatives expected from Johns Hopkins and Georgetown. And we know today's a timely dialogue with the changes to climate shifting a lot of the ranges of many of the disease-carrying species and infections rising globally. Greater need for more research, enter a lot of folks like our research universities, and with HHS and CDC releasing its proposed national strategy, and we're surely to hear more about this framework today. In that regard, we're also honored to have leaders from across the federal landscape here today. We'll start off with our leaders from the White House, with the CDC's present today. BARDA plays a very important role at HHS, USAID, FDA, and also important partners like CEPI, as we all know. Final shout out to some special guests. We know we have the state of Florida's Washington office represented, National Governors Association, some staffers from the delegations of Texas and Florida. Special shout out and thanks to the support by Valneva for helping make this possible, and our partner Jen Alton with Pathway Policy. So to get us started, let me give a quick run through of the program. We're gonna, and by the way, when it comes to question and answer session, we'll have microphones that you can use. Will be provided by our team. We know you're going to learn a lot from our panelists, but I know that our panelists and experts want to learn a lot from those that are here, so we do expect this to be interactive and in our questions. We'll start with opening remarks from Dr. Matt Hepburn from the White House Office of Science and Technology Policy, and then we'll have a series of 4 quick response topics. We'll start off with the economic impact of the Chikungunya outbreak potential by Dr. Lori Pennington Gray from the University of South Carolina and Dr. Krista Court from the University of Florida. Advances in Chick detection and surveillance from our wonderful colleague, Dr. Aaron Staples from the CDC. Medical countermeasure innovation for outbreak control from Dr. Jerry Parker, our partner in this effort from Texas A&M. And then we'll wrap up with our own collaborator and colleague, our good friend, Dr. Carlos Espinal, from our own FIU Global Health Consortium. Quick plug, you have some information on our annual conference that takes place this September, as well as, in some of our discussions earlier, we were also talking about influenza. He has a workshop taking place here next month on influenza. We can circulate more information on that. So it's now my honor to introduce Dr. Matt Hepburn, currently the Senior Advisor to the Director of the Office of Science Technology Policy for Pandemic Preparedness. Previously, he served at the Vaccine Development Lead for Countermeasures, Acceleration Group, formerly known as Operation Warp Speed. Also at the Joint Project Lead for Enabling Biotechnologies for the Joint Program Executive Office for CBR and Defense. And this is after 23 years of serving in the U.S. Army and with his final assignment at DARPA, as we know. Dr. Hepburn, welcome.
Great. Thank you. Can you hear me? Is my microphone okay? Yes?
Daniel, is the microphone catching for
We are.
virtual?
Yes. Microphone good? Microphone relatively good?
Yeah.
Good enough? We'll figure it out later? Okay. I'm happy to do that. Hey, I'm really happy to be here. This is fun. I see a bunch of old friends in the audience too, actually. Jared, good to see you. Like Jan. I mean, this is, so that's kind of the fun part. Although I think when I was approached to speak, I sort of said, we'll get into it, but I'm obsessed with chikungunya and why it's so important. And I'll explain that to you. I do want to take some question and answer, but I kind of want to talk to the students a little bit. So, I mean, that's like, of all the audience, I got old friends in here, that's great. Got government people, that's great. I kind of want to talk to the students, and especially at the end, sort of a little bit of inspiration, advice, and things. And I was thinking about this too, and I was like, you know, my kids are college age. They don't listen to me. Most people in the government don't listen to me. I was like, hey, we worked at Operation Warp Speed, so we did. No one cares. You know? But my thought is, maybe the students, maybe if you can listen a little bit, or even if you don't, I can at least try. So it's going to be a bit cathartic for me, okay, to sort of give you a little bit of unsolicited advice before we finish up. So I want to talk about two main things. The first is sort of pandemic preparedness, pandemic innovation, where are we at, and then kind of a why chikungunya, or how does it fit in the bigger context? So I think, anytime we talk about COVID, we have to say, we have to remind ourselves of the tragedy that was, and the tragedy that was obviously on a global scale, but also intensely personal to all of us. The people that have died, long COVID, economics, mental health, the disruption that it's caused in all of our lives. We can't just sort of say, okay, well, let's pretend that it didn't happen. And I think what we're seeing now on a societal level in the United States and globally is this collective wish that we could just kind of forget about it and move on. And I think instead of saying, we can't forget about it, I think we have to sort of acknowledge that in some ways and say, okay, we get it. People don't want to talk about COVID all the time anymore. But I think especially for those that are in this world of health and public health and vaccines and things like that, we also have to say, essentially be resolved that we're not going to forget about it. So we're just not going to let that happen. Now, maybe we won't remind people as much, or maybe we have to figure out another way to get things done. But in the spirit of, we have to remember that we can never let this happen again. But we also have to be appreciative that we're in a very different world. And where it reminds me a lot, actually, is after we had the H1N1 pandemic in 2009. And after that, 2010, I had a chance to serve at the White House in the Obama administration. And I was just having a bunch of very fruitful conversations today. In that, there was a similar kind of, H1N1, we thought it was going to be horrible, and there was this perception that maybe it wasn't as bad. In our government, we went through a process that was called sequestration, which was they were going to cut, everybody gets a big cut kind of thing. And so as I was thinking about that time and place, I think it was helpful to remember that even if it feels like no one really cares about this issue, or no one cares about global health, or no one cares about infectious diseases, we got to stay at it. You got to stay in the fight, and we have to work. We have to be resilient. We have to be determined, because what I remember from 2010 and 2014, 2015 is that a lot of the efforts that I saw my colleagues do were the key things that helped us get through the COVID pandemic. And we can talk about a lot of examples. There were early investments in RNA vaccines. That was a good idea. There was developing a whole agenda around global health security. It's kind of a wonky, jargony government term, but it means that both the national security professionals and health professionals are going to work together on a global scale. And that was like a new idea, and now it's really commonplace. And so there are a lot of those things that sort of give me hope, if you will, but that we need a set of dedicated professionals that are going to just be at this. Okay. The one thing, though, if you would say, can you distill down, Matt, of what you think we should do to prepare for the next pandemic? I would distill it down in one word, and that's do. And that's action. The best way that we will be ready for a future pandemic is if we don't talk about it. We have to talk about it, but we got to do stuff. We have to take action. We have to use the government jargon term is we have to exercise our capabilities and blah, blah, blah. I came from DOD, so it's like, okay, exercise your capabilities is a national term. But what we're talking about is this idea that the things that we are going to do now from a public health standpoint in addressing outbreaks are the things that are probably going to be most useful when that future pandemic happens, or future big outbreak or epidemics. Who knows what the future holds in terms of what is the next thing going to be, what is 5 years going to look like, what is 10 years going to look like. But I am convinced that the best way for us to be ready is for us to address public health crises now and get really good at that. And get good at it at a community level, get good at it at a national level, as a government level, and also get good at that at an international global scale. If we work together on a current thing that's right in front of our face and that we got to do something about, we're going to get used to working together, and we're going to get better each time we do that. We don't always get better. It's not always like this. Every time we respond to an outbreak, we get better. It doesn't work like that. Sometimes what happens is we respond to an outbreak and then everybody forgets about it and they go do other jobs and there's no money and we actually get worse. So it's a fits and starts type of process, but generally speaking, the trajectory will be that we will be much better for future outbreaks. Does that make sense? And like everything I do at the White House right now in the Office of Science and Technology Policy, we're focused on innovation for next pandemics, is that premise. Why chikungunya? There you go. So I've been working on chikungunya when I was at DARPA. We were interested in chikungunya vaccines. We actually did a whole challenge on chikungunya and forecasting with available data. When we had chikungunya, if you remember, in the mid 2010s, chikungunya is reintroduced into the Western Hemisphere. We see a massive amount of cases. We use that as, if you will, an exercise to say, can we predict the spread of a vector-borne infectious disease, and how well can we do? And we ran a whole DARPA challenge around it. The point with chikungunya is that, first of all, it's a horrible infection. It's an infection that, I think oftentimes when we talk about infectious diseases, we're like, it's sort of like a which one is worse type of conversation, which is a horrible conversation to have, right? And it's sort of like, but we do this, and we're like, well, we have to set priorities, so we're gonna work on this instead of that, or we're gonna, and it's a painful and difficult and weird conversation to have. But I think sometimes when people talk about chikungunya, they're like, okay, well, it doesn't cause as much death as some of these other infections. And it's an incredibly silly way to think about a problem. But I think that does come up a lot. I think the point for me with chikungunya is that it causes long-term sequelae in a ridiculously high percentage of people that are infected. And what that means is, you are in so much pain that you can't work. And any infection that causes you to be in so much pain that you can't work has massive economic consequences, which I don't even appreciate or measure nearly to the extent that we should, because we don't have all of the data to truly understand and characterize that. But for me, that means it's a hugely impactful infection. That's point one. Point two is I'm firmly convinced we can either eradicate it completely, or we can very, very much mitigate it so it doesn't even come up on the threshold of diseases that we can talk about in the future. Wouldn't that be cool? And the reason I say that is because, at least in my limited understanding, you're going to hear from the experts today, my limited understanding is that if you've been previously exposed, that you are immune from subsequent exposure for at least a pretty good period of time. How long? We don't know. We have to do the science and data and sort all that stuff out. But if you look at patterns of infections in cities and such, I'm pretty convinced that it happens, the population achieves a certain amount of herd immunity, and then it just doesn't come back again. And it doesn't come back for a while, not because the mosquitoes aren't there, because they still are. It doesn't come back again because the population has achieved enough herd immunity to protect them, at least for a certain period of time, right? So why is that important? What then that tells me is that if we can figure out what a protective immune response looks like, and we can give a vaccine that replicates that protective immune response, we can seriously control this infection. That make sense? And for other diseases, that may or may not be true. And influenza, wouldn't it be great if we had a universal influenza vaccine? That's an infection because of mutations and everything else and respiratory transmission. It's very, very hard to achieve vaccination that is truly, truly protective for an extended period of time. I think for chikungunya, I think this is very achievable. And therefore, if vaccine can be truly safe and effective, then we can then say, okay, now we have at least one tool in the toolbox. And I also think we can use tools like antiviral treatments, which we don't have yet, but broad spectrum antivirals are on the horizon. Maybe they'll work for chikungunya, and monoclonal antibodies as well. So treatments, vaccines, next generation diagnostics. We take advantage of all of the progress we've seen in home diagnostic testing with COVID and point of care. This box can, you run it on a PCR in a box instead of a lab and all of these other things. Between those three, I just can't understand, I can't see a technology problem that prevents us from essentially eradicating chikungunya. I just don't see it. It's not, it is very achievable in my mind. So then you say, well, why don't we? What's preventing us from achieving that objective right now? Well, it's us. It's us as human beings being organized, committed to saying we're not going to let this happen anymore. And whether that's resources or partnerships or communicating on vaccine hesitancy or having diagnostic tests that are available for everyone, highly accurate, where they are in their homes, diagnostic testing for everyone. All of that's achievable. We just have to get organized and we have to be resolved to be able to do that. If we do, we are exercising for the next pandemic. And that's why I think both chikungunya is super important because this is a solvable problem for us now, but also as we solve this problem and collectively work together, we will be best prepared for the next pandemic. All right, so here's the unsolicited advice. And you are allowed to roll your eyes. We're sort of simulating the children. You roll your eyes and check your phone. Now's a good time. Check your phone. And then go, no, I'm listening. I really think, I think the future to be a health professional, defined extremely broadly, is incredibly bright. I think what COVID taught us is the importance of this mission, all of the massive technology that can come to play, but also essentially the revolutions in diagnostics and AI, of distributed manufacturing, and all of that other technology. And the people that are newer and more familiar with next generation technology will have a massive advantage over the people like me who are like, I can't even figure out how to use my cell phone. And I'm like, I'll throw out AI as a buzzword, and that doesn't work anymore. But I don't know what I'm talking about. Do you know what I mean? So the point is, as a student, as you develop interest in this field, you are going to be able to leapfrog, just absolutely leapfrog previous generations and previous experts who are going to be stuck in their old ways and are going to be like, it's too hard for them to learn out of the way they are. One of the fundamental lessons of the pandemic is you can't just learn health. You have to understand psychology and anthropology, and you have to understand economics, and you have to understand data science. Everyone needs to understand data science. And so if you are interested in doing this going forward, it is a really special time to do that. I would strongly encourage you to do so. And not only because I think it's going to be profoundly exciting, but also because we really need you. We need you to eradicate chikungunya. We need you to help us prepare for the next pandemic. Thank you. I think I'm going to do a couple questions, yeah?
Yeah.
All right, great. All right, questions. So they kick me off stage. Should we, why don't you go first?
We're going to bring a handheld mic to you, so just put your hands up and we'll get you the mic.
Hello. Okay. Hello, everyone. Good morning. Thank you so much for coming in and speaking to us today. My name is Naomi Bridget Williamson Kundasa, and I'm coming from Tanzania. I'm majoring in international relations. And so in regards to what you're talking about, Chikungunya, I just discovered from my friend Alvin, she's from Uganda, and Chikungunya is a word derived from a tribal language in Tanzania, and the disease itself was also discovered in my country. So my question is, what are you currently doing to educate the public, especially in Tanzania? Because personally, I did not know about this disease. And knowing that there are so many people in Tanzania that tend to move around Africa and also outside Africa, there's a big possibility that this disease is being spread and the government itself is not even aware about it. So what steps are being taken to educate the public in Tanzania, Africa, and other countries as well? And my other question is, once the vaccine has been developed, there's a lot of misconception about the vaccine, So what are you going to do to make sure that everyone understands that it's genuine, you're trying to really help people in Africa and also outside Africa? Yeah.
Such a good question.
Thank you.
So I'll answer the first two parts, and then I'll work on the third one's the hardest one. First part is, so as we roll out any vaccine, we need to work together as an international community to figure out who gets vaccinated, when they get vaccinated, and what is the best way to reach everyone, wherever they live. Through that international cooperation, we will get better at future vaccinations. We'll get better at childhood vaccination. We will get better at the next pandemic vaccination or anywhere else. But we have to sort of start with the idea that when we roll out vaccine campaigns, we need to make it equitable, and we need to make it equitable, resource it, and we actually have to do a really good job with it. But it should be for everyone. The second point is, you said, but we don't know how much chikungunya is out there, and are people even getting sick from it? And that's exactly correct. And that's where I'm so inspired and frankly obsessed with diagnostics, because the idea of if you could do a test strip like COVID and be able to say you have chikungunya, yes or not, would be transformative. If you could at least even just be able to collect a blood sample and be able to send that to a laboratory and have a way to say yes or no with accuracy, but also to be able to reach people wherever they are, that's also transformative. So there's a lot that we can do in diagnostics everywhere that will give us an idea of who's getting sick and when they're getting sick. And then we can figure out who needs vaccine and who doesn't need vaccine. The third question's the hardest, is how do you educate people about an infectious disease, and how do you educate people about vaccines? And so, when you ask me that question, what I will say is I'm going to ask you that question, because one of my fundamental premises in terms of COVID is that we as I would say government and as a society approached COVID like we're going to communicate with people through traditional ways for which we used to communicate. Like, we're going to talk, we'll do an interview on television. And how we communicate as a society has changed dramatically. And I feel like your generation understands that better than we do. So the solution to how do you educate a public on health, how do you explain to people vaccine, how do you explain factually, how do you communicate with them where they are and understand who they are, that's where we're looking for the solution from you.
Hi, thank you for coming. My name is Maika. My name is Maika Eugene, and I'll graduate in 2 weeks with my Master's of Public Health in Health Promotion and Disease Prevention. And my question is kind of a twofold question as well. So you talked a bit about the morbidity and mortality debate, and as well as like the long repercussions of the incidence of disease. And then also you talked about innovation and as it relates to the culture of the industry. And so my question is how do you continue to still grab like fresh minds and really bring them to the table when it comes to innovative ways of like health communication, and also developing research and other research methods, but then also being able to remain equitable when it comes to these conversations?
Yeah, so I think great questions and really hard questions. I'm going to answer a little bit philosophically and then try to be super practical. Philosophically, if you want to encourage someone to innovate and try to do new things, the worst thing you can do is tell them it can't be done. Well, maybe there's a small percent that are super motivated by that too. So it's sort of the, so maybe I take that back. Maybe that's exactly what you should do, is tell them it can't be done, and then they'll commit. What I mean is that we, unfortunately, I think we have a lot of systems in our society which discourage innovation, which discourage creative, disruptive thought. I think we reward groupthink. I think we reward the same old, hey, if you're going to get a research grant, you have to agree with what everybody else agrees with, and then you're going to take that next little step. And that we don't sort of encourage creativity and innovation and disruption. So fix that. But I think, again, talking to an academic audience, is that this is a place where that can be done very well in an academic environment, or it can be, the best ideas can be suppressed. And so the challenge is to, as one example in an academic environment, to reward that disruptive creative thought. The second part is, I think a lot of the best innovations comes from a discipline in another field that you bring to your thinking, and it changes that thinking accordingly. And so that's what I mean in terms of health communication. Health communication is like a little bit health, and it's mostly communication. And there's a lot of great work being done in psychology and anthropology and neuroscience and everywhere else where we are learning about that. And so I think that's where we have to take a lot more of that and put that into practice. I've seen a lot of people talk about it. I'm not sure. I think it's a field ripe for fixing because what I just told you, I haven't necessarily seen the super practical example. But I hope that we can kind of encourage and nurture that different type of approach. Yeah. Yeah. You want this one? Or we were behind you.
Good morning, everyone. My name is Tiara Campbell. I'm a pre-medical student. I major in biology, and I'm a rising senior. Before I started this journey, I was a national swimmer for Jamaica, but my time was cut short because the cartilage in my knees wore out. So what really helped me to even walk again was a stem cell surgery. And with that being said, I researched, and it said that 60% of Chikungunya victims, they suffer from joint pain up to 3 years later. So I was wondering if a stem cell surgery or like a trial could help these individuals, and would it be economic stable for this to happen?
Yeah, it's a really good question. And so into and I don't understand the true origins of the name, but it does really refer to that chronic, really painful joint pain, which is a hallmark, and it's really bad. I think once you have it, there's not a lot we can do for it. If you look at current medical science. And so that's what, for me, that means is this is why we have to do everything to prevent it in the first place. And then we have to have accurate diagnostics, so as soon as you're sick, you get treated. But we need treatments. So we have a lot of work to do on that front end, because once you have the chronic joint pain, it's very difficult to treat. But I do agree with you. I am excited about a lot of the different new treatments that we're seeing in healthcare for a lot of chronic conditions that, again, these things weren't treatable. These things are not treatable now. They could be in 3 to 5 years because of all the new technology and innovation. Got a lot of questions. That means I'm going to stay longer. Just understand, if you've asked me questions, then I'm like, that means I got to stay. Go ahead.
If you want to take multiple at one time, we can do that too.
You want to do that? Why don't we do, let's try like 3. 2 or 1, I don't know, whatever you want. Go ahead.
Hello, everyone. My name is Aidmuhambiatova Nazirke. I'm from Kazakhstan, and my major is Health Services Administration. And I'm working on vaccines for shingles. And just had a question. As we embarrassing technology more than ever, the innovation in digital health has put a spotlight in health equity. This brings me to my question. When a new vaccine is developed to cure previously uncurable disease like a chikungunya, how will this vital information reach the communities that don't have access for television and internet?
Yeah. So let's do 2 more questions and I'll bundle. Yeah. It's a really good question, though.
Hi, my name is Noemi. I'm a first-year MA in English Literature, so definitely get behind the multidisciplinary approach and would love to talk to you about your trip to Puerto Rico after this.
Absolutely.
But my
That was
question
an
is-
amazing trip, by the way.
Sure it was. Great
sorry,
food, great
I'm
culture.
sorry to digress, but yeah, keep going.
Good. I always love to hype up my people. But I have a bleeding disorder, so I experience a lot of joint issues and mobility. And as my colleague mentioned, that's part of something that happens with chikungunya. Said it right. So I was curious if there's any collaborative work with other communities that have chronic illnesses and maybe have similarities in some of the symptoms that they're experiencing, and maybe if there's potential there for you guys to understand maybe some of the ways that we navigate issues with mobility and joint issues, and how that could also benefit your research in the future.
One more bundle? I don't know how I'm going to bundle this, but.
Hello. Oh, hi everybody. My name is Michael Clark, Jr. I double major in biology, pre-med track, and natural applied sciences with a minor in chemistry, and I graduated in the summer. And I wanted to ask, in terms of equity, I feel like vaccine rollouts, they often miss the ball in terms of being equitable to the people they want to serve, specifically BIPOC, LGBTQ people, as well as like international people. I wanted to ask, like, what do you guys have in place? Like, are you guys outsourcing DEI professionals, or are you outsourcing like certain individuals to then like properly target the audiences you want to get the vaccines out to quickly? Because I feel like historically we have missed the ball like on every single vaccine that has come out in terms of serving the people that actually need it.
Yeah,
So.
I'll try to answer the similar theme between the three, but make two quick comments. First, this is a great group. It's really amazing. I don't think I appreciated the international component and also the diversity of perspectives here. It's extraordinary. So very exciting. I was invited by the Puerto Rico Manufacturing Association and visited in the fall, as well as had a chance to meet with their Department of Health to understand their COVID response. And I think it was, I'm glad you brought it up, because it was a really good example of a community that responded to the pandemic really well. And it's a community that was with a vulnerable population, and but that community had worked together in emergency response. That was one of the key lessons when I'd spent a whole day with the Department of Health. And what they said is, look, we worked together in emergency response, and we knew where people lived, and we knew how to reach people where they were. And we had done that very routinely for a long period of time. So when COVID vaccination came available, they had one of the highest vaccination rates of any state or territory in the United States. That was my primary point. For those that were listening at the very beginning, that they had worked together on hurricanes, and they took it very seriously that they needed to reach everyone, and that enabled them to have one of the best COVID vaccination programs in the country. To kind of bundle the vaccine and equity questions together, we have a lot of work to do in terms of really reaching kind of these communities. One of the things, maybe to go back to my previous point, is that we're trying to learn from places that were able to do this well, and that's why the Puerto Rico example, I think, is particularly appropriate. What every community will tell you is that the most compelling way for them to be reached is someone who understands them and is part of their community. So the expression was sort of I visited a state of North Carolina as another example that did a really nice job with vaccine outreach. And the community health workers were like, and we said, how did it work? It's like, because of community health workers. They said, what's your secret? And they're like, because we're in the zip code. We are in the zip code. We go to church here. We're part of the community. My kids go to school here, so people listen to us. And I think if you take that lesson and you say, apply that regionally, nationally, and actually globally, if we're talking about how do you reach people without internet, or where do people get their sources of information, the best people that know that are the people that live there and the people that live that experience. And so, we have to figure out how to reach people where they are, and that's the most effective way to do that. Here's the hard part. That's hard to do, and it actually takes a lot of money. So when we talk a lot about how do we resource future pandemic preparedness, one of the main points I make is that a lot of things can be done through innovation through the private sector and philanthropy and things like that. The private sector can develop really good vaccines. What I don't think the private sector will do on their own is to figure out how do you have public health outreach in those communities. And I think that's a public good that you're going to have to resource. So when we think about what are our resource priorities, I always put that stuff at the top of the list. Figuring out how to talk to community health workers who work actually with those people who understand those people, and those are going to be the trusted messengers. We just have to then, from a policy standpoint, commit to resourcing that. Okay, do we, maybe one more bundle, or am I done? You kicking me out? They didn't ask any more questions, so.
You have to go.
I think I do have to go, too. that's another good point, Jen, thank you. Great. This has been really fun. Have a good, it's like the end of your trip, so it's like, welcome to DC. Well, that's not helpful. But when you go back, and Miami's a wonderful place, by the way. It's a beautiful city, so I am a little envious that you are going back to Miami. But yeah, just stay in the fight. Keep up the good work, you know. Don't let anyone discourage you. It can be done. Thanks.
Speakers. Krista and Lori, please join us. There, as I mentioned before, they're going to cover the potential economic impact of an outbreak. Welcome.
Thank you. Hi, everyone. Thanks so much for having us. It's so exciting to be here, and I just want to echo what Matt said. It's such a great experience to be able to be in a room with so many diverse backgrounds and perspectives that are here, especially things that will help us to address the challenges that exist for chikungunya. And so you might wonder why a professor of tourism is here. And so one more perspective that is going to be able to share in conjunction with collaborations with economics, one of the challenges of trying to quantify what the impact of an outbreak would be in the United States. And we were approached a few years ago now to be able to address this question, and notwithstanding all the challenges that exist without existing data, this was something that we've realized was important to be able to do from a collaborative perspective. And I had spent 22 years at the University of Florida, and Krista and I knew each other slightly, and this enabled us to work together a little more collaboratively. And
Just so we can make sure.
okay, sure. Then I can move to this side too. So it was a great opportunity for us to come together and discuss how were we going to be able to operationalize the variables that needed to go into the model to be able to predict what the impact of an outbreak would look like. And so it took a lot of conversations, and you'll see that our methodology was quite exhaustive, so that we could come together and be able to defend some of the data that went into the model that Krista will present at the end. So that's how we got here. I also run a research lab at the University of South Carolina. My area of expertise is on crisis management. And so I spend my time looking at the impacts to the tourism industry when big disasters, disruptions happen globally, locally, et cetera. We've done research across natural disasters, health crises, terrorism, et cetera. And there's similarities that exist among those things, and there's also nuances. And a lot of times, I also enjoy what Matt said, that we have to bring together communities that have not traditionally been able to speak the same language and talk together to be able to address some of these concerns. And without the perspective that Krista and I bring to the table that look at things differently, we wouldn't have been able to address this question and answer the question of what is the economic impact to a region if there is an outbreak from chikungunya. And so we would have loved to actually have had multiple people at the table to address this. The healthcare industry is important. We also would have included local officials. We were able to borrow some of the data that existed from previous outbreaks, but it wasn't simply enough to just say, let's do that and apply everything we know from A to B, which led us to doing the research that we engaged in to be able to come up with the final numbers that we will present. And I am going to use this for the first time, so here we go. Let's see. Oh, didn't work. There we go. So in my field, it's well documented that economic losses happen when there are health disruptions and health crises. We've seen that across things like Ebola, H1N1, and Zika. And scholars have come together with practitioners to be able to document what the economic impacts are. Ebola in Sierra Leone, we saw that there was a decrease in 50% of the arrivals to that country as a result of Ebola. We also saw during the H1N1 pandemic that we had an impact of $55 billion US. With the Zika outbreak, there were short-term economic impact losses of $3.5 billion. These are big numbers. They're important because we want to be able to provide a context by which the impact exists. How important is this? People understand when it comes down to dollars. So having the numbers are important for us. Ooh, too much. So why is this important with chikungunya? Well, we know that we've been able to document that mosquito-borne diseases are on the increase. We also know that in the past decade, it has tripled in the amount of diseases that are documented. We also know that approximately 1 million people die worldwide each year due to diseases transmitted by mosquitoes. What we don't know is what that impact and what the context and likelihood of a chikungunya outbreak would look like. And so that's what brought about this study. We wanted to be able to look at what it meant if there was going to be an impact in the United States. And so in order to do that, we looked at 3 different studies to compile the data. The first one was the use of a Delphi study. That's using experts in the field to be able to determine the context, and we have questions that we used and asked of the experts. We also did a consumer behavior study or a tourist study. This was important to understand what the impact would be for visitors to that destination and how likely they would be to change their behaviors. And then those 2 pieces of information, the data that we received from that, went into the economic impact model. And so without that data and doing that primary research, we would have had to rely on existing studies and just transferred that information. So instead of doing that, we went to the source and asked questions. So with the Delphi study, we went to entomologists and infectious disease experts. We asked them to comment on the possibilities of a chikungunya outbreak. We also asked about the possible repercussions of that, particularly with the impacts to the tourism sector. And then we asked how prepared the US was if there was an outbreak. We talked to 12 participants. Of those 12, 7 were women and 5 were men, and they represented the states of Florida, Kentucky, and South Carolina. It was through a snowball sampling technique. If any of you students have taken research about this, you know what that is. So we asked people to refer somebody else that we should speak to, and we did that until we got to the point where we had exhausted names. So it's a small group, but was fairly representative of experts in this area that people thought we should speak to. And the findings were that chikungunya was highly likely, that there would be travel-related cases, and that the majority of the pathogen would enter where there was heavy air traffic. It would be spread through mosquito bites, obviously, and that the magnitude of the outbreak would depend on the awareness of the destination inhabitants, so those that lived in the area, how aware they were of what this disease is and what chikungunya is and how to protect themselves. And then also the implications of mosquito control. So whether people were controlling mosquitoes, spraying for them, controlling the population. The research in the past has also shown that, the more that people understand about the impact of the bite of the mosquito and how to protect themselves, the more likely they are to engage in that behavior. So without the knowledge of the behavior, they can't engage in it. So we have to do this educational campaign in order to make people aware. We also know that people won't come to that area if the media releases information and says there's an outbreak. All right, so more people are likely to stay away. But we didn't have the details on the percentage of individuals that would completely change their behavior, whether they would go somewhere else, whether they would postpone their trip to a location, or whether they would do nothing. So through this, we realized that it wasn't enough to stop here. We also had to ask travelers. So that was the impetus for the second study, where we did an online survey through Pollfish. Are you guys aware of that one? Yeah, I see you nodding heads, good. And we asked 500 international travelers a series of questions, mostly about knowledge, awareness, personal protective behaviors, likelihood of travel, how often they travel, what kinds of activities do you participate in when you go to a destination. In this case, it was a destination outside the United States that was endemic to chikungunya. And our findings suggested that 28.4% had previous knowledge of chikungunya, but 25.5% had heard of it but didn't know anything about it. So those numbers are fairly small, and we need to increase the amount of people that are aware of it. We also know that 50% felt anxious about it, and a lot of that is tied to the notion that they don't know anything about it, right? So they hear this thing, it scares them, and they're anxious. And so the likelihood that that translates into travel behavior is greater because of lack of information, lack of knowledge. So we saw that 30% would postpone their trip, so they would wait and go at another time if there was an outbreak in an area that they were set and booked to travel to. That's a large percentage, and it's meaningful for the economic impact piece of this. 50% would travel, but they would engage in protective behaviors. Again, whether they knew what those protective behaviors are. Wearing bug spray, wearing long clothes, pants, long sleeves, etc. 15% would look for another destination completely. They wouldn't go to that destination at all. So most of you that live in Miami would know that that would be a huge impact to the economy if they said that they're not going there because of the fear of a disease that they might capture. And 5% would do nothing at all. So those are your risk averse. They're not doing anything. They just don't care. They're going anyway. They're like, bring it on, I don't care, we'll deal with it if something happens. Small percentage, and they exist, right, across all types of risks. So from this, the findings were then filtered into this economic impact model, and I'm gonna turn it over to Krista, and she's gonna share how we use that data in order to create the model.
Thank you, Lori. All right, so I'm going to digress just a little bit to tell you about myself first. So I'm an assistant professor in the Food and Resource Economics Department at the University of Florida. My particular expertise is regional economic modeling. So we're the quantitative data people looking at economic structure, what happens if there's a change in human behavior or activity associated with industrial activity. And this was the first time that I've been approached to do something on an unprecedented event with very little data in even a similar event to happen. So to give you a flavor, in the last 2 weeks, I've talked about a new meat processing plant coming to the county that I live in, changes related to red tide, Hurricane Ian. We do a little bit of everything. And I really appreciate the interdisciplinary audience here, because about 10 years ago, I was in DC interviewing for a job, and one of the questions that they asked me was, if you were at a table in a room with economists, what would you bring to the table? And my answer was, boy, I hope I'm never in a room with just economists. I did not get that job, but that was the moment that I knew I did not want that job if that's what I was going to do every day. So, but what we needed to do is distill, we needed to come up with a situation, and I described it to Lori as there's an art and a science of figuring out what is that input to the models that we have that are already based on databases looking at economic structure in a particular region. We know how industries are linked to each other, and we know how they're linked to things like government institutions, as well as the final demand coming from consumers. But the literature didn't tell us what was going on. So we used the information from the Delphi and from that tourism study to look at what do we think that outbreak would look like specifically for the tourism industry. And so we saw from those studies that the chikungunya outbreak is expected to have similar characteristics to the 2016 Zika outbreak. So it might happen in the same areas. The transmission is similar. The seasonality of when these mosquitoes are the most active, that are the vectors, would be in these places. And because of the things that we've talked about before on morbidity, mortality, it's not going to close the hotels. It's not going to be like a COVID-19 shutdown, but you are going to see residents and visitors that avoid outdoor places or engage in these other preventative activities. And it will reduce the attractiveness of the place. So essentially, visitors may not want to go there, or they may not pay as much to go there if they do still visit. And you see some of these populations like children or the elderly that are more apt to get some of these long-term conditions may behave in different ways than the rest of the population. The other thing is that media coverage, and especially social media attention, can affect visitor plans and visitor behavior. So we needed to factor in, what might happen if the outbreak happens in a particular area in other regions of Florida. Or one of the things that we see when we look at water quality impacts is that people from outside of Florida, when they hear about a red tide in the national or the international media, think that the entire state is shut down, and this is happening all over, and it's terrible, you can't go to the beach anywhere, which is just not the case. So during the 2016 Zika outbreak, what we saw is an outbreak in the Wynwood area in Miami-Dade County, and noticed that what we were looking for is how did visitation change during that particular outbreak, if that was going to be the one that we could say was most closely related to a potential chikungunya outbreak. We had data from a company called STR. We looked in the Wynwood area and noticed that the average occupancy rate from the same part of the year in 2015 was 84.9%, and then it had declined to 80.5% in August of 2016 when that outbreak was taking place. So we can see declines in the occupancy rate. We also see declines in RevPAR, that's the revenue per available room, which is another metric that we can look at. And we noticed that if we broadened that out, or we looked at other areas of Florida, we also saw declines, more moderate declines in the entire Miami-Dade County area, or also looking into the Orlando area because of that media attention. It's still Florida. It's a tourism destination, and we still did see that there were some declines there, even though we didn't see the types or the number of cases in this particular outbreak. So this was just additional information to what we were seeing in the Delphi, that there was an impact for this, and this was a similar type of situation. So what we did with our model, now that we had some reasoning behind the numbers that we were going to use for this potential outbreak or a hypothetical outbreak, is look at a 4% decline in visitation in the Wynwood area, and also a 2% decline in visitation in the Miami-Dade area and the Orlando area. That's the decline in the number of visitors. That's not what goes into the model, though. So we still had some more work to do in order to translate that into these economic models. What we needed to know is how did they change the amount of money that they spent and what it was spent on because of this decline in visitation. So you'll see we have data from Visit Florida, which is our tourism bureau in Florida, that tells us about how much each visitor spends on what types of things. And we'll use that information to translate into expenditure dollars. So it was about $20 million just in the Wynwood area that was lost because of that 4% decline in visitation. $82 million in Miami-Dade County and $226 million in that Orlando area because of that 2% decline. So this is across several different categories. They're spending on lodging, they're spending on entertainment, and they're spending on food while we're there. And that's what we use to drive these models. What that translates into is across the entire economy, how many jobs do you lose? We lost 244 jobs. These are job years, so they may come back when the outbreak is over, or at least in the following year. We're not sure how long they decline for, but 244 job years just in that Wynwood neighborhood. About 992 jobs when we look at that Miami-Dade County model, and 2,569 jobs in that Orlando area because it's such a big destination. There's so much spending going on. These are just additional metrics that we can look at, so losses in sales, sales revenues for all of these different industries, and these do include multiplier effects. So the tourist doesn't spend money where they were going to spend money, then doesn't spend money on input goods and services that are available in the local economy, and that goes on and on and on through multiple rounds of spending. Value added, similar to gross domestic product, you can see the declines there, and we can also calculate the declines in tax revenues, so whether that's local, state, or federal level taxes, which is often something that the county and local governments are very concerned about. I think that's all we've got. So we've barely scratched the surface on a nearly one-year project, hopefully in 15 minutes, but we are looking forward to the questions because they're very good questions coming out of this audience.
Please speak into these so that way they
Sure.
can, yeah.
Hello, thank you for being here. So I just wanted to look at the slide, if you can swipe, because I have a question about some of the information on there.
Which
previous one?
Previous one?
Yeah. Yes. So you spoke about the Wynwood area, which is also historically Overtown as well. And I'm looking at the occupancy rate, and I was wondering, are there any other like social determinant factors that were maybe factored into this as to why there was a decline in the occupancy rate?
No, we didn't look at what was driving those declines in this particular study, but you could. And so you could look at what different types of visitors or different types of places that they were staying. So this does include both hotels and peer-to-peer accommodations. But we did not look at what was driving those in particular. It lined up with what we were hearing from the Delphi and what we were seeing in the literature, so we stopped there in order to move forward.
Okay, so it was strictly for the Zika outbreak. Like that's the metrics that we're looking for.
Yes.
Okay. Thank you.
Hi. First of all, thank you so much for your presentation. I was a little curious if in the future your research was going to look at the specific economic impacts in areas like Wynwood in the Miami area and even Orlando in the minority populations that exist in those areas, since Miami is known for its large Hispanic and African American population and Orlando is known for it as well, if there's some interest in how it may affect them worse off or the type of impact it would have?
That's a great question.
Yes, so I'm giving you the 30,000-foot view, right? Like what happened in all industries for the entire time period. There are data that are in the model now, or that you can connect with the model that look at, if we look specifically at the jobs lost, we can see what are the occupations within those particular industries that were most impacted, and then you can connect that with data from places like the Bureau of Labor Statistics to decide, like, was it minority positions that were more affected? And often in the tourism industry, you see that that is the case, or those are the first jobs that you'll lose when there's declines in visitors. So we did not do it as part of this study, but it is possible to dig deeper into that.
Thank you.
Yeah.
Hi again. So I was actually born and raised in Orlando and have lived between Orlando and Miami, so I definitely see the differences between both. And for reference, in Central Florida, not just Orlando, but Central Florida, the Disney parks are the largest employer. Second is the school department, which I have family members that work in both, like many people who live there. So I know you touched on a lot of the effects that media may have on getting this information out and addressing misinformation, but back to that media part, one of the things I see between Orlando and Miami is that because Miami is predominantly Hispanic, we have a bit more of a dramatic approach to our news cycle. It's like extra fear-mongering. So knowing the role that news plays in fighting disinformation and spreading accurate information, especially in this term of economic impact, I was just wondering, where do you intend to take this research, and who do you plan to talk to address maybe that aspect of media and making sure we get information out in an effective way, and also to people who maybe don't have English as a first language?
That's a great question. That's an excellent question, and you know, having spent 20 years in Florida, Zika is not the only disaster or crisis that Florida has faced, and communication is a huge part of that. There's a huge amount of research that's looked at messaging and the recipient of the message, and so I appreciate your question about the method and the message. And I think, you know, Florida has taken typically a top-down approach with government, and that funnels through Visit Florida and then Visit Florida's partners. And so they unify the message so that it goes out to all of the stakeholders so that everybody's championing the same message. And in many ways, I think that's an effective way of disseminating the message. But I think what your question is maybe alluding to is the fact that different audiences receive the message different ways. And so our previous research, when we looked at hurricane evacuation and Katrina, found that different audiences responded to that evacuation message differently. And so the African American population was more resistant to a government message, and they really turned to clergy and the churches to be able to communicate those messages. And I think there's still a lot of work to be done in Florida where we start to reach out to different audiences that may look to authority figures in different ways and weave them into that messaging. I'm not sure we're there yet. I'm not sure that all the stakeholders are represented, even with Visit Florida, and I would honestly say that Visit Florida has one of the best models in the U.S., especially about having partners and extending that partners beyond a traditional tourism partnership. But I'm not sure that if we looked at being able to communicate to a specific audience, whether all those individuals are at the table. And so that's a lot of work that could be done. And that is something that we, in our research, we continue to do, is trying to build out our research and our partnerships and the messaging. And COVID was a great example of that. And it's not just in Florida, it's globally, that we realized that our traditional group that was at the table expanded, and we continue to need to expand even more and weave more into the conversation and be more interdisciplinary and multi-sectoral. And so I love the question about a Latino population, but I think it goes beyond that. There's other populations that also may need to have representation at the table so that whatever that message is could be crafted in a way that would be articulated so that we get a better response to personal protective behaviors and messaging that we're asking like audiences to engage in. So whether that's, you know, to evacuate or to wear bug spray or to, inform people that it's not as much of a hazard as it appears to be because the media has overblown it. So I could go on about this topic for a long time since this is something that I've been involved with, but I do agree that we're not there yet and that COVID kind of opened our eyes, but I'm feeling like we're a little complacent and we aren't taking it that next step. And I think, Matt also said the same thing. We need to continue to build these partnerships and bring more people to the table. And this is a great example of that. So let's continue the messaging and the partnerships and take that to the next level.
That is why we have a working lunch. Our panelists can go on and on. We do want to keep the trains running on time. So up next, we're going to, as I mentioned, we're going to ask Dr. Aaron Staples, of the CDC, to cover some of the advances in chick detection and surveillance.
Thank you. Thanks so much for having me. I was listening to Matt talk, and I was like, oh, H1N1, I was in Chicago. Chikungunya, yeah, I was in the Caribbean. Zika, I was in Brazil. Oh, we didn't even mention yellow fever. So I spend a lot of time with the CDC trying to actually get the information to help people on the ground take care of whatever emerging issue is. So I'll try to actually, in this talk, I'm going to talk about virus detection and surveillance, but I hope to fill in some of the gaps that some people mentioned about what is chick and why does it do this, what does it sort of do in sort of its disease presentation. So, and I am not going to be competent at this, but I'll use the arrow. So I want to start with kind of walking through with what do we know, where are we at now, and where are we going next, in terms of chikungunya. So chikungunya virus transmission, just to take one step back, make sure everybody's on the same ground. Chikungunya virus transmission occurs in tropical and subtropical regions. We do see outbreaks in temperate areas, so Italy was a good example of an area. We've seen actually disease cases in Florida before. We can see it in more sort of these outlying areas, and as climate change happens and we see the vectors expand, could we see it in New York City? Absolutely. Those are things that could happen. So we do see right now chikungunya virus is going to be in the same areas with other similar vector-borne diseases. These are transmitted by Aedes aegypti mosquito or similar Aedes mosquitoes. So it's like dengue or Zika. Where those are, you're going to find chikungunya. So because the cycle predominantly is a human and a mosquito, things that drive either of those populations is what's really going to influence where chikungunya is going to be seen. So transmission is impacted by weather, environmental factors, where your vectors are located, your existing population immunity and population density. More people together, more mosquitoes, great place for a chikungunya outbreak. So there are basically two patterns of chikungunya virus transmission that we see. The first is really kind of ongoing, low level of transmission with periodic outbreaks, okay? This is occurring in countries, usually kind of in our continents or landlocked areas of Africa, Asia, Central and South America now following the first round of outbreaks. What's happening is people that are naive, don't have a good immunity, or haven't been infected before, they're getting the virus, they amplify it up in their blood, mosquito bites them, the mosquito brings it to another person. So that's really what it's going on. It's a human-mosquito-human cycle for this. In terms of outbreaks in this setting, they're unpredictable, but they do occur. It's when that virus is spreading and eventually will get into that niche of the population where it can expand. And I'll show you that actually visually in just a second because I'm a very visual learner. So in terms of, in comparison to kind of these larger countries or areas, we do see a different pattern in our island nations. So we do see that an outbreak occurs and then it stops. But we do think there's still going to be risk as things go on. So we do have apparent and interrupted transmission when there was an Indian Ocean island outbreak, the Pacific island outbreak, and even in our Caribbean area, we have seen some cessation of that transmission. But as our population immunity wanes, as new birth cohorts come in, as people move away, new people move in, you start to build up your susceptibles again. So this is a curve. Everybody's like, well, were you in Panama? No, I was in Panama talking about them how to change from getting spreadsheets from Excel and trying to automate that so we can actually get real time. So if anybody's doing informatics or even thought about it, please do that. We need a lot of informatics in public health. Okay, so the chikungunya outbreak in Paraguay is happening right now as we speak. Okay, so in the Americas, there was a large outbreak of chikungunya that started in Saint Martin in 2013, and then spread throughout the whole region. Almost every country, except for Canada and Chile, pretty much was affected. Uruguay also, if you want to throw that in there. So it was one of the genotypes called the Asian genotype. So Paraguay actually had their first outbreak of chikungunya back in 2015. But they were kind of, thankfully for them, a little bit on the edge. It happened in Asuncion, which is the capital and the central district around there. Then the next year, during the rainy season, when their vectors are peaked and the transmission can happen, they saw another blip. Nothing for a year. Then they actually saw another little blip. It was on the northern part of their country, which borders with Brazil. There was spillover for some of the activity in Brazil. It was from the East Central South African strain, which is, thankfully, your immunity to the strains, well, they're different strains, still works to cross-protect. So there was another little blip, which actually, blip means hundreds of cases a week. That's still a lot to handle in a healthcare system that might not be prepared. And then we go a little bit of activity, October 2022. This is what chikungunya does. This is a large, explosive disease. If it gets into a population that has no population immunity and the right vectors, you're going to see this. Now, these are just confirmed and probable cases. They had more than 5,000 cases a week. You can imagine in a place with even think about Miami and the number of hospitals you had. If you had 5,000 sick people showing up in your emergency room and some proportion of those, 10%, getting hospitalized, you start to cripple the healthcare system. So they were getting over 15,000 cases reported a week that they had to investigate and take care of in public health. And that outbreak, unfortunately, is still going on. It started in Asuncion in the central region. It's now spread out to the rest of the country. So this is a good example of kind of that low level of transmission with periodic outbreaks. This was actually just published over the weekend, looking at the outbreaks in Brazil in a place called Ceará State, which kind of sits up at the top of Brazil as you're kind of going like this. So they also had their first introduction in 2015, similar to Paraguay, but they didn't really have their first outbreak until 2016. And that was in the north central portion of it. When they had their next rainy season and when their vectors were active, they actually got a much larger peak, and what happened is it actually moved into Fortaleza, which is their capital, very densely populated area, ended up with much more larger explosive outbreaks. Over the next years, it didn't quite go away, but it ended up, circulating at a lower level, not knowing exactly when that outbreak is going to get. But then it finally took hold in the south part, where there was less population immunity due to the previous outbreaks. So that's what chikungunya does. It looks for that niche. It wants to expand, it wants to grow, it wants to survive. It does that by finding susceptible humans. So this is in contrast what happens in island nations. So Indian Ocean, there's a bunch of islands down kind of near off the coast of Africa that were affected. And this gives you kind of an example, and I'll show you two things here. Maybe. Oh my gosh, there we go. Ooh. So first, Comoros is an island nation with has 3 different islands, and they had an outbreak, and then they didn't actually see anything, and they haven't seen anything since that one outbreak. They're done, at least for now. They're going to be accumulating more susceptibles, but we're almost, pushing 20 years, and they haven't seen any more outbreaks. In contrast, La Reunion had basically a very explosive outbreak. But what happened is that they had the virus introduced kind of in the dry season, so they had some activity. And then the rainy season came, and all the vectors were busy. And then all the vectors started hanging out with people. And bam, that's bad news. So there was over 4,000 cases reported a week there, and that's a population of less than 1 million. So even just a quarter of the size. It's one neighborhood in Miami, for that matter. So all of these places have not seen any further outbreaks of it, but we do expect eventually that the virus will be reintroduced. So we do see those two different patterns. So just to summarize what I talked about in terms of the features of outbreaks, location. You're going to see it in areas with low or no population immunity, where there hasn't been any outbreaks in the recent past. It can be localized if there is one niche, or it could be widespread if there's a lot of susceptibles. What we see is that very sharp peak, like we are seeing in Paraguay. We see a rapid increase. We see up to 30 to 60% of the population can get infected during any period of time. We don't think the widespread outbreaks that we saw in the Americas back in 2014 and 2016 are going to happen again. Why? Well, we have population immunity. Most areas had places or people that were infected. But we're going to continue to see large outbreaks. Paraguay is a good example we're living through right now. So we do see that it's going to increase, and we always know, rainy season, oh no, there goes our diseases. We know that's happening, so we should be able to use some of these tools that Matt talked about, the innovations, the clever minds in this room, to really get ahead of that, to figure out and launch on that. And then, of course, we see this very intense period of transmission. So when we think about therapeutics or we think about vaccines, the just-in-time or just-in-case, if you don't act right away, you don't recognize it, you're in trouble. So where are we now? So, of course, I got asked to talk about detection and surveillance. So there's two components of detection and surveillance that I've just mentioned, mosquitoes and humans. So what we do know about chikungunya, it likes Aedes species mosquitoes. So Aedes aegypti, Aedes albopictus, Aedes henselae. Those are the mosquitoes that are capable of ingesting the virus, replicating it, and essentially, when it bites you, regurgitating it. I could say vomiting, but that's essentially what it does. So mutations, chikungunya is clever in that it has had a few mutations which allowed it to expand in different areas. This is actually the genome shown with the proteins, the structural. So the light green are non-structural proteins, and these are structural, which are kind of shown in these nice, pretty figures over here. So what we saw in 2005 is that there was just one amino acid change in the nucleotide in the envelope protein 1 that was an alanine to a valine switch, and you basic science people, switch at this amino acid, and it changed it from being something that's spread easily by Aedes aegypti to easily by Aedes albopictus. What that did is that virus could then get into the populations of humans that were susceptible living more closely with albopictus than aegypti. Okay? What are we seeing now? Well, right now, there are two mutations. It's also in the East Central South African strain. It's not in the one that has this mutation, but two small changes, one in E1, the envelope 1 protein, and one in envelope protein 2. It allows the virus to replicate more rapidly in Aedes aegypti and makes it more transmissible. So we are seeing larger explosive outbreaks. So this virus is pretty clever and kind of a pain in my butt, but that's another whole story. So what do we know about just in terms of surveillance? We know that it, in areas where there's intense circulation, you can just take a mosquito and you test it, you're going to find the virus. It gets a little bit more tricky with a sporadic transmission. Sometimes it's actually like looking quite literally for a needle in a haystack, because there's tons of mosquitoes, but you have to find the right one that bit that one person that is kind of trying to spread it around locally. What actually is the best thing, for better or for worse, for surveillance are humans. Why? Because based on our previous serosurvey, most people that get infected develop symptoms. This is unlike dengue, where most people that get infected don't have symptoms. So there's a bit of amplification and circulation even before you realize it's there. With chikungunya, it's not subtle. I have talked to so many patients with chikungunya. Doc, at 1:05 in the morning, I woke up with this horrible headache, with this horrible fever. I was shaking chills. It is not subtle. And it's because of the rapid onset and the severity of the symptoms that humans are actually a really good sentinel for this disease and something that we can follow and track. But it has to be tied with awareness in the community. So a lot of the points already questions brought up, you have to make people educated about it. Because if the clinicians aren't suspecting it, they're not going to order that diagnostic test. They're going to send them home. They're going to get bitten. You're going to get amplification. So those are two things that we really need to know and do in what we try to do at our public health agency. So chikungunya is now nationally notifiable. That means that if a disease case occurs, it needs to be notified and sent to the state health department, who sends it up to CDC. So what does that mean for us? Well, we can track how many cases. And we know since 2016, there has been no local transmission in US states. And in our US territories, there's been minimal transmission since 2017 and no transmission since 19. But we do still get plenty of travel-related cases. And in fact, the travel-related cases can tell us where things are going. So this just shows you the regions of probable acquisition of travel-associated chick following the outbreaks in the Americas. Actually, most of our chick cases are coming in from Asia right now. India has a pretty good sizable outbreak, and it continues to circulate there. But we're not seeing a lack of it in any other region for that matter. And in fact, in North America, Mexico, we're still seeing cases come up from Mexico. So things we have to be paying attention to know where the virus may be coming from. So there was some mention about modeling. Even during the last outbreak, my colleagues and I did a nowcast model. There's lots of different modeling, and it hurts my head sometimes. But nowcast means using the information you have now to really know what's happening. So in that case, we use, okay, the virus is here now, we know. This is the air travel, and this is the climate where that person might end up, and what does it look like? And we were able to use that. But that was based on no or minimal immunity. We know that most areas in the Americas have had some degree of infection, but no one really knows what is that point estimate for this location, and that's going to influence it. So we really don't know. It's a little less clear how many infected travelers is it going to take to spill over to a local transmission. We do have some sources of data, but they're limited. I just mentioned the travelers that come into our surveillance system, Ministry of Health websites. Paraguay did a good job of putting everything up as soon as it happens. I can send you the link if you're interested. Our World Health Organization, specifically PAHO, puts up weekly counts, but it's only as good as the surveillance system in those regions and how that's going to reflect. So what's next? Don't worry, I'm almost done. Good news is we do have some experience. We've been there. This is not our first chikungunya dance. I've done chikungunya, I've done Zika, I've done yellow fever, but it's not our first dance. We do have preparedness plans. We do have surveillance systems able to do it. We do have, thankfully, diagnostic testing platforms. We don't have point-of-care tests, so that's something for Matt to really work on. But we do have that in most of our states and territories, and there's also commercial testing. So we're in a much better place than we were last time when this happened. So we also have prior experience with Aedes surveillance in the United States. We can surveil for them, test them, and do our best to control them. You know, we have experience from chick, and we also have experience from albopictus. From Zika. We also have social media, which is good when it's used appropriately. It can be challenging sometimes when it's not. But for instance, with a Healthcare Alert Network, that sends out a message to clinicians, anybody who pays attention, hey, this issue. So we sent out an increase in chick in the beginning of March in Paraguay. What happened? The next week, we had 10 testing requests of people who didn't know they were already infected. In a way, we were already behind the ball, but thankfully it's very cold in March in New York City, for instance. So we didn't have any, but those are different ways that we can be better prepared to get our messages out. But then last, I just wanted to talk about evolving tools. So we already heard about some vaccines, and I'll mention that in a second. But there's other things too. There's vectors in this, so there's a lot of sterile insect techniques that clever scientists are working on. Basically, the World Mosquito Program has infected male mosquitoes with a bacteria which makes them sterile. Oxitec has genetically modified male mosquitoes to make them sterile. Sorry, guys. It's all about the guys. And then there's also the male mosquitoes get irradiated. Then they get sterile, right? The whole idea, the premise is the sterile males mate with the females, and then they can't produce offspring. So these are all things that are currently going on and is being evaluated for ways not only to control chikungunya, but to control dengue, to control Zika. So there's different areas and avenues that people can think about for research. Just a summary, chikungunya is likely to change by location, influenced by several factors. So we can do and predict and hope and try to be clever, but unlike the previous outbreak in the Americas, we're going to have to deal with some uncertainties. We have population immunity, which is great, but we also still have susceptibles. We have existing surveillance guidelines. We have early warning systems that we need to use to be better, and we're going to have to tap into novel prevention strategies to take care of this. So with that, I'm just going to end, and I'll turn it back to our moderator.
Well, you can use that microphone.
I'll use this microphone. I brought paper because I don't always remember. Okay, 3. Then I need to write it down. Yeah. Okay.
Yeah, I'm John Bogdan from the Department of Defense. We're more interested in the encephalitic alpha viruses, but we have some interest in chikungunya. I was reading several articles about the introduction of new mosquito species in Florida, and there's been a number of new introductions over the last 5 or 10 years. And could you comment on that and their capability to spread not just chikungunya, but other arthropod vector viruses?
Second.
Hello, my question is, you mentioned effective strategies such as detection and surveillance in humans, and how can these strategies be implemented since there are differentiated possible severities in different geographical areas? And how does the CDC collaborate with other agencies and organizations to monitor and respond to outbreaks of chikungunya, both domestically and globally?
My question is just more of out of curiosity. So we had a dengue outbreak, I think in 2019 in my country, and we had lots of people who died. And I just wanted to know if there was a vaccine that was probably developed in the long run, because I've seen it's something that you guys are also focusing on. Yeah, that's all. Thank you.
All right, I'll try to go ahead and answer those efficiently. So in terms of strategies first, different mosquito species, CDC is aware of and is actually liaising with several people in the state health department and the ag department to look at those mosquitoes. There's a challenge with mosquitoes to not only knowing can they get the infection, but are they competent? So we have to do actually laboratory studies with any new species to figure out are they, and that's what we do at CDC. We generate kind of real-time public health research to answer those questions. Is that new mosquito species gonna be able to transmit this virus or that virus? And until we actually challenge it and put it into the lab, I'm gonna tell you, I don't know. I think that's our answer right now, but that's something that in working with our state partners and working with everybody around the world for that matter, we work together collaboratively to understand, okay, there's a new species. Let's figure out what it's going to be able to do, particularly for human health on our side. And then the next question is different, oh my gosh, see, this is why I write it down, but I don't always get it right. So strategies in different areas, and then you also said how CDC collaborates. I can definitely talk to the CDC collaborates in different agencies. So for the Paraguay outbreak, for instance, it's all hands on deck. My colleagues, and I've been at the Pan American Health Organization for the last couple of days, they were sending down some people initially for clinical expertise. Then they wanted some help with the surveillance system, so I went to Panama to meet people. And then they wanted some additional assistance to really help aggregate their data and understand and really work on their communication messages. We had our personal experience. We had messaging both in English and in Spanish, trying to make it in Arabic and other languages to make it easier, accessible to different groups. So we had colleagues on the ground, people abroad. We're working all together to try to help with the acute public health crisis. I think one of the things Matt said that's always challenging is I go from one public health crisis to the next. sometimes being able to even collect ourselves and say, what could we have done better? How do we need to change things? That's always the struggle and the balance that we have. But we do work very closely because we are the US federal government. CDC doesn't just show up. We have to be invited by another federal government. So, but once someone asks us for help, we're there. You know, that's usually how we work. And then in terms of vaccines, I didn't catch exactly the outbreak in Tanzania. With Tanzania, I was going to say, Anyonyon is probably more common than chikungunya, but we can have a discussion offline about that. But I mean, I think vaccines are, it's very good for this sort of disease, and Matt already covered it, in the sense that we think that a vaccination, you know, can protect against all the different strains that I just mentioned and the mutations. That's going to be able to protect humans. The biggest question is vaccine uptake. You've already asked those questions. What is the vaccine uptake? How do you get it in people's arms? How do you actually get to the people that are most susceptible? I've worked a lot on yellow fever vaccine, so I've spent a lot of time working in Nigeria, working in Uganda, working into other places of how do you get to that community. And as already mentioned, it's the people on the ground that know how to get there. They know how to connect with them. So you work within that infrastructure to get, you know, the devices or whatever you have to those people that you need, you know, that are most in need. And that's what we spend a lot of time doing at the CDC. So.
Okay,
I'm
in the
getting
spirit
cut
of
off.
keeping the trains running on time, it's now an honor to introduce, and we're going to beam him in virtually, the leader of FIU's own Global Health Consortium, Dr. Carlos Espinal, that for our guest here today did have a previous era in Washington, D.C. in pharma world, but for the last 5-6 years has been doing great work leading our own collaboration across the Americas mostly and globally. So Dr. Espinal, I believe you can hear us, and we'll soon find out if we can hear you. Not yet. Give us 1 minute. Waiting for sound. Can you hear us, though?
Yes, sir.
I've already given them the plug for the September conference in Cartagena. Are there travel vouchers?
Okay.
Take it.
It will be for some people, for sure. Well, thank you very much, Carlos, and the FIU, and really getting a lot of knowledge about many of these important topics. I'm the director of the Global Health Consortium at the Department of Global Health at FIU, the College of Public Health and Social Work. And we work very close, let me tell you, with the Pan American Health Organization. We have an excellent partnership with the PAHO arbovirus team in order to accelerate implementation of the control and management strategies for arbovirus and different diseases, including, of course, chikungunya. I should say that chik today is a disease of concern due to the serious outbreaks that we have seen now in Brazil, in some cases in Argentina, and especially in Paraguay. And it's of concern because we have observed an increase of lethality, almost 59% of increase of lethality in this outbreak. We always considered chikungunya as a serious disease and with complications and so on, but low mortality and low lethality. But we have seen now a change in this pattern. And what is more important is that unusual presentation in some age groups, like in children, especially neonates and newborns, with an important number of cases in Paraguay, almost 132 cases in newborns, and this excess of mortality. Well, I shouldn't say excess of mortality yet, but a high mortality that was not seen before. Perhaps, as pointed out by our colleague from CDC, the change of the genotype from the Asian genotype to the African genotype, plus the lack of immunity in the community since the last outbreak in 2014 is producing or is favoring these important changes that we have observed during this outbreak in 2022 and 2023. Therefore, we really need tremendous effort because now with the climate change and the expansion of vectors, we are going to see a lot of outbreaks and cases of different vector-borne diseases, including dengue, chikungunya, and no question about that Zika will come in the near future as well. Though all these diseases have not disappeared at all from Latin America, they remain in the low endemicity with small outbreaks, but now what we have seen in Chik is really of concern for the region. We have almost 270,000 cases between 2022 and what we have now in 23. And we urge the countries to be prepared to increase surveillance, to increase case detection, case management, and to really implement early vector control strategies to prevent the spreading of this disease. So partnership is extremely important today. There's no one single institution that is capable to manage and to control if we don't go into common efforts and international collaboration. We certainly have 7 areas of priority for international collaboration and partnerships. First, to understand the impact of climate change and health in our region and the expansion of the vector-borne diseases, including arboviruses and chikungunya. Second, to innovate in models of disease surveillance and early outbreak detection. We are still very, very behind the schedule in our region in innovation in disease surveillance and diagnostics tool for these kind of outbreaks. And following with the innovation, we need to innovate in mosquito control strategies or vector control strategies, and also in access to early clinical management of these diseases. And now that we have a potential vaccine in the horizon, it's very important to prepare with anticipation the vaccine introduction and the vaccination scenarios. I think vaccine and new tools for diagnosis has a tremendous potential for these diseases. And even, as I said before, with the expansion of the vector-borne diseases due to the climate change. Climate change is real, it's a real threat, and it will be affecting not only in Latin America and the Caribbean, but United States as well. In another time, we could present this impact of climate change and the expansion of vector-borne diseases in US. That is a terrible picture. So as our colleague from CDC said, we really need to work and anticipate this critical situation. Finally, we need to prepare the community. We need to work and empower the community and to really do some more participatory research on health and social determinants for these diseases. The community, we should involve the community in the early stages of our initiatives, and not just when we have the outbreak in place, because there is already late. Just an economic cost of chikungunya, just to remember that in 2016, Danielle Bloch made a fantastic study on the economic impact of chikungunya in Latin America, with a total cost of $185 billion, not counting the cost of interventions, vector control, clinical cases management, and so on. Just the medical impact was that high. So this is a call for all of us to participate, to work together, to elaborate into the international collaboration with these and these 7 or 8 specific and very relevant components. Finally, my congratulations again to Carlos and Becerra and his team for the organization of this magnificent event. And thank you very much to all of you. You are very welcome to the Global Health Conference of the Americas, where we have a very important session with the Pan American Health Organization and countries in the region on control strategies for arboviruses, including, of course, chikungunya. Thank you very much for your time.
Thank you, Dr. Espinal. I know you've got to get going, as do we, but time for one or two questions, if anyone has, for Dr. Espinal. Okay, then I think it's my honor to bring in our closing speaker, but how appropriate that he's our partner in good things today, Dr. Jerry Parker from Scowcroft Institute and Bush School. Thank you, Jerry.
Well, thank you very much. I'm Jerry Parker. I'm the director of a pandemic preparedness and biosecurity policy program at the Bush School, but also associate dean for Global One Health in our School of Veterinary Medicine. Just to get to know me a little bit, most of my career was in federal service, the military, and also DHS, HHS, and DOD, in biodefense, health security, pandemic preparedness. And so I'm going to try to get the trains back on track so we end on time for lunch. I'm the only one standing in front of lunch, and also your travel home, and I got to travel home too. So I'm going to kind of like change up everything that I was thinking about talking about, because this has been a great conversation. And your questions have been extremely thoughtful. I mean, extremely thoughtful question that you have, and really gives me a lot of optimism that those who follow us, who have been in this business for a while, are going to give us a better world. Because you're thinking about these things in a much more holistic way than our generation has. And so I'm extremely optimistic of the future, because you're already thinking about how to solve some of the global challenges, globally and locally, in multidisciplinary teams, and that's what's necessary. And my generation grew up and we're educated in silos. And I see just from the thoughtful questions that you have that you're not constrained by the silos that we grew up in. So we talked a lot about the technical details of chikungunya vaccines, surveillance, epidemiology, and et cetera. And so I'm going to try to bring it up just a little bit. So chikungunya really is a story of emerging and re-emerging infectious diseases. And there was a period in time just 30, 40 years ago that the scientific, medical, public health community thought we had conquered emerging infectious diseases. We were moving on to cancer, to cure cancer. We had childhood vaccines, we had a smallpox vaccine, and we really were making a dent in infectious diseases, and then HIV. And there were a number of re-emerging infectious diseases and new diseases. The National Academies of Science in the United States even did a study in 1992 that was a wake-up call. Bob Shope, the other one, I'm having a senior moment, but he was an advisor for DOD, were leaders of this National Academy study that there was a wake-up call that we got to start paying attention to emerging infectious diseases. Soon after that, CDC actually launched a new strategic plan on emerging infectious diseases, but we still were kind of complacent about it. We can no longer afford to be complacent about emerging and re-emerging infectious diseases. Chikungunya, that we've seen the devastating consequences, is just one of many that we need to pay attention to. And also the chikungunya, that we look at the details and look back 50 years, it's also a story of the absolute need and commitment and investment in the scientific enterprise. I mean, we need professionals, we need, what Aaron described, took hard work and years of work to understand the epidemiology and the genomic and the molecular mechanisms of why, and understanding why it's spreading now. And there are different vectors that are spreading it to other regions of the world. That's incredibly important, that knowledge, and how we can control chikungunya and other emerging infectious diseases in the future. They're all different. And we have to have that investment in the scientific enterprise to understand those differences. And we are on the precipice right now of actually having some vaccines and new innovative diagnostics and surveillance tools, but it would not have happened without a commitment in long-term investment in science and people like Aaron and many others in the public health preparedness and biodefense space to make this progress, but it's not easy. And chikungunya is also an example of why it's not easy. The science is a little bit hard. Fortunately, a vaccine is achievable because of our understanding of its characteristics, but the business model is hard. How are we going to afford the several hundreds of millions of dollars to actually develop and field a vaccine? The regulatory pathway has not been clear. And fortunately, the FDA over the last 20 years has also invested in regulatory science, and they've become innovative in their thinking about how do we license and field some of these vaccines that are essentially orphan vaccines that there's not a large market. And so regulatory pathways also got to be innovative, and fortunately our colleagues in the FDA have been doing so. And it's taken a long time to do that. And we think about COVID-19 and this spectacular success with fielding a vaccine at 11 months, which was a spectacular success. But it was built on 20, 30 years of scientific investments and understanding coronaviruses, mRNA technology, and other vaccine platform technologies. And so that's the kind of, we have to continue that commitment and that investment. And unfortunately, our population and society, even our political leaders, seem to be complacent at the moment. And I'm not afraid of saying that, because we are. And we're tired of COVID. We're tired of the pandemic. But we may be tired. I'm tired of it. But we've got to continue to keep up the fight, as Matt told us, to make sure that we get investments in these things. And then one final thing that I think is going to be very important too, as we think about fielding, say, a new vaccine or new therapeutic or new diagnostic, we got to get it to where it's needed. And there's some tremendous lessons learned in the COVID vaccination, distribution, administration that we haven't even begun to understand yet. And I'll just share a little bit from my own state of Texas that I think resonated with me, but we haven't really truly learned these lessons yet, lessons observed to turn into lessons learned, is how do we reach those underserved communities? And we didn't do a very good job of that. And how do we prioritize a scarce medical resource when everybody wants it and needs it? And that's a hard challenge too. One thing I know that we did in Texas that I think was helpful is the Department of State Health Services, Public Health, that was in charge of this, actually partnered very well with emergency management. Land-grant colleges, Texas A&M University, got very involved, and we have they have a lot of logistics experience. But importantly, we began to understand, at the community level, and who are the trusted voices at the community level. It took us a little bit to figure out how to reach those underserved communities, but you got to find those trusted voices in the community that's been spoken about several times today. So those are kind of the things we've got to pay attention to these things. Chikungunya is yet one example. It's an important example that we got to tackle. And as Matt said, it's good we have to exercise our plans, and chikungunya is a way to exercise our plans for pandemic preparedness. I like to use another term. We have to breathe life into our plans. Breathe life into our plans. It's got to be something we do every day to breathe life into it. So I think I'll just stop there. So want to take any kind of any questions that we have in the remaining time.
Questions for Jerry.
I was just going to ask, how do we move those hundreds of billions of dollars that are vacuumed from a system due to a vector-borne disease over into where it could prevent that from happening?
Sure. Yeah. So I mean, we need to work together as a global community, and we have to have partnerships, across the globe. International collaboration is absolutely essential, and the U.S. actually the United States over the years has done a pretty credible job of thinking about, through our U.S. Agency for International Development, of how do we make the right capacity investments around the world, particularly in low-resource countries, whether it be for food security, water security, more recently in global health over the last 20 years, like HIV and TB, and now for pandemic preparedness and health security. And how do we invest in, what are the right investments through U.S. aid that we need to do, let's say, for health security? I think we need to return to some of the basics, like education, not just training. And this is where FIU, Texas A&M can play a role. Training is very, time limited. And we need to be thinking about joint degree programs and education that's longer term. And it's harder to do because our political leaders think in short term, 2 years, 4 years. So, so we need to be thinking longer term, and that's education. And that's where we can really bring something to bear. But we need to be thinking about the basics in public health diagnostics, animal health diagnostics, reporting, those kind of things. And there was a question here.
Hi, thank you for being here. My name is Megan Foro, and I'm a first-year psychology major. So I know you had mentioned that sense of complacency, and as we see with COVID, there was a lot of complacency in terms of not wanting to isolate and not wanting to get the vaccine, things like that. So how do you plan on fighting that sense of complacency with the vaccine, as well as just proper care and treatment?
Yeah, I think we have to really go back to the basics. Right now we find ourselves in a situation where trust in some of our institutions is fallen, whether that be our government institutions, whether it be our public health institutions at all levels, whether we trust in science, and I think we have to really come to grips with that and recognize it, don't ignore it, and we have to listen. We have to do a lot of listening, and we have a lot of hard work to rebuild some trust in our institutions, and then come with that, we have to find the trusted voices in our communities that can help us in that journey. It can't be just somebody at a podium like me or somebody like Aaron say, take your vaccine. We really have to find those voices, but we also have to be very honest about what is the efficacy of this vaccine, what is the safety of this vaccine, and assume the public can understand that data and information. And so every vaccine is going to have some type of side effect. Let's just talk about it. And more often than not, the benefits far exceed the side effects that may come from a vaccine. But we just need to be full disclosure in these kind of things. It's not just, it's safe and effective, let's take it. And that doesn't work as we've seen.
Hello, Patrick Dennis, Captain, retired PHS Public Service. Asper was my last
all right.
station. So
proud FIU alum.
Yes. Yeah. Oh, yeah. Thank you. I was just going to forget about that. Great. I wanted to say really excellent speakers today. Thank you very much. I guess my question is that in my 30 years of dealing with all of these different types of responses, so to speak, is how do we introduce within each community a different way of thinking about their lifestyle? And let me just give a context. Everyone here probably is on autopilot when they're driving, okay? Or they're walking, or they're looking at their phones. They're thinking about so many different things, daycare, bills, things like that. How do you introduce, they hear something on the news that is about Zika or Chikungunya or COVID, right? How do they process that? Because it's not part of their daily living. It's not part of their lifestyle, so to speak. So I think health behavior could be a way, coupled with health communications, in introducing that into communities along the way. Just a thought with you and your
I think that's a great idea.
Thank you.
I mean, because health is important to all of us, and you're absolutely right. I'm overwhelmed with everything I got to deal with on a daily basis. I hope I'm not autopilot while I'm driving, but I probably am when I'm listening to my iTunes and so on. But our daily living, our diet is important, and we think about those things, and we think about just our health. Is this, I just almost had a scare that I thought I had a retinal tear, and I'm still dealing with, floaties and visually. But daily health is important to us, and so there's an opportunity to maybe inculcate in our daily thinking about healthy living that there are some low probability, high consequence events that we should not ignore. So I think you're absolutely right that there's an opportunity to think about that in our healthy lifestyles and healthy living, that we cannot ignore the low probability, high consequence events. Because hopefully chikungunya doesn't hit one of us, but it may. And if it does, we've heard and now know the devastating consequences that it could cause on an individual. And my heart's always in Asper's. I was used to be the principal deputy. Any? Yes.
Hi, my name is Diana Dupelord. I'm currently a pre-nursing student. I just want to say thank you for coming here and speaking to all of us. So my question is kind of similar to his. I just wanted to ask, do you think what was implemented in the Texas A&M University can also be reinforced to other institutions, not just universities, but for like elementary, middle school, and everything else, for them to gain access to efficient and reliable education? Because I know like in different communities, because I know education plays a big factor in people wanting to learn and educate themselves.
No, it's very important. In fact, I just was invited. Just real-time story. I was invited this morning, emails. I was trying to, multitask, but there's a group I know in just College Station and retired professors in AgriLife, and they've started a nonprofit that's Texas and our statewide, but can apply to any country, any province, anywhere. But it is focused on how to reach elementary, junior high, high school students, particularly in underserved communities, that their family may not have had college graduates in their family before. So how do you reach young people, children, and older children, that particularly in underserved communities, and how do you encourage and how do you catalyze interest in actually pursuing higher education? And things like that. So I think there's things we all can do, and I'm going to attend this event and be there to at least see what I can do to try to help this nonprofit that I think I've been very inspired by what they're trying to do, and their reach across our state is pretty tremendous. And they're just retired professors in AgriLife, and they have roots in agriculture and food production, and they're trying to serve and attract those students who may not necessarily have had the opportunity to pursue higher education. And I think all of us, can do that in our communities wherever we are from. As we continue our career journey, we always think about how do we contribute to our community. We may be working on big policy stuff, like I was. When I was a commander at USAMRID 25 years ago, I used to always think about how could this high containment laboratory that seemed to be mysterious to the community, how could we be more open, and how could because I lived in I lived in the community too, and my children went to school and we went to church, but I worked hard to make sure that the community understood what we were trying to do. We were trying to do it safely, securely, and the mission was important. So with that, I guess I have some closing remarks.
Yes, and I think Jen was going to join you, or?
Okay.
No, close.
Well, Jen, do you want to say something first? Well, first, I just want to thank you so much for the opportunity to join you. I'm mentoring. Let me share this. So, in the spirit of Matt earlier this morning, mentoring is a bilateral relationship. You always think about somebody that's already been in the workforce and so forth is going to be served as your mentor. Let me tell you, I get more from you than you get from me. And so mentorship is bilateral, and I've had a wonderful experience just being with you a couple hours a day. Your questions were just extremely thoughtful, and again, I have a lot of optimism in the next generation, and that our world's going to be a safer and more secure place and prosperous place because of you, and the energy that you're already bringing to helping solve some of our global challenges at local levels, and that's going to be key. One thing that is going to be important, your voice matters. You know, whether it's chikungunya, whether it's emerging infectious diseases, whether it's food security, water security, climate change, your voice matters. And you have to speak up, and all of us have to speak up. And this is how we influence policy if we're not in government and sitting in government. In fact, I think sometimes you have more influence from the outside than you do from the inside. As Matt said, sometimes you say something in government, nobody pays attention. That's true, right? That sometimes was my experience. But you can have a tremendous impact from the outside. But you probably want to pursue a career in policy and maybe government service, but it's all public service. Whether you're in government, whether you're in the private sector, whether you're in a nonprofit, whether you're in academia, whether you're working at whatever level, community, local, state, government, federal government level, it's all public service. I think all of you, I can tell you're inspired by public service and what you can do to help our fellow persons. So I would just encourage you to continue to do that. Some specific things that are coming up, at least in the United States, that I think we have our voice can make an impact is Congress is considering reauthorization of the Pandemic and All Hazards Preparedness Act. It's going to happen, I hope, this year, better, because it will expire this year if it's not reauthorized. So I think it's important for the pandemic preparedness enterprise and the biodefense enterprise. So we need to pay close attention to that and see what kind of input that we can, and our voice can matter in that reauthorization, because it's just essential to get that authorized. There's going to be also some national plans for viral diseases that we need to pay attention to and help influence and elevate the importance, in this case, of chikungunya, and the need to get some of the medical countermeasures and innovation across the goal line for this and other emerging and re-emerging infectious diseases. So we have responsibilities as citizens to help our elected officials try to get these things right. And so with that, I just want to thank everybody again. This has been a wonderful event, and I look forward to partnering with FIU in the future on these global and local challenges. So thank you very much.
Sure. And once again, thank you to Dr. Parker, our colleagues from the University of Florida, USC, our partner with CDC, Jen and Amanda, our partners in this endeavor. We thank you all. We do have lunch available in the rotunda. Please feel free to take your time. You can come back here, or we have for our special guests that are joining us from associations, the conference room is also available in case you need a place to hang your hat. So thank you so much. Thank you, Jerry.